Hello, I'd like to invite you to International Women's Day 2022. And today we have Aoife Harvey and Dr. Sarah Callaghan, who have come here today from their clinics over Zoom to discuss intimate women's health. Over to you, Aoife.
I'm going to be talking about your pelvic health going from like pregnancy, which is usually when pelvic health issues start, and then right up to perimenopause and menopause. And Dr. Sarah Callaghan's going to come in and talk about hormone changes in perimenopause, so you know what to look out for. And these symptoms I'm going to talk about are really, really common, but a lot of women don't report them to their doctors because they tend to just be an embarrassment or a quality of life issue rather than feeling like it's a health issue. But it really can impact your quality of life, like not wanting to go for long walks or not want to take part in sport because you're leaking, or having issues with painful sex and affecting your intimacy. So I really hope it just educates lots of you and empowers you to go out there and look for help with these symptoms, because they are really, really so common. So I'm just going to start the presentation now. Okay, and there's Sarah's email address and my email address, just in case anyone wants to contact us afterwards. So what is the pelvic floor? So firstly, to know that these are a group of muscles that connect from your pubic bone. Can you see me there, Mary? Connect from the pubic bone right back to the tailbone. So they're a big group of muscles all on the base of our pelvis, and they support our pelvic organs, which is really important, support our uterus, which is our womb, our bladder, our rectum. So all these things are very close together in the body. And as you can imagine, when you have a baby and something comes out this hole being the vagina, it can absolutely impact the other holes around it and the support system of your pelvic floor. So it's quite often why none of us ever hear of our pelvic floor till we're pregnant, because that's when issues start to arise, or after the baby's born, or again, sometimes in later life. But just so you know that these muscles down here are like a hammock supporting everything in your pelvis. So if they're weak or there's a problem with them, they will impact things like your bladder and your bowel function and the support of your uterus. And that's what women's health physios do. We really rehab the pelvic floor muscles, because they're a group of muscles, a really important group of muscles all on their own. So I'm going to come back to this now. So how do we strengthen them? The first thing you might know is that it's all connected to your breath. So a lot of women might leak when they cough, sneeze, laugh. That's because their diaphragm is moving. So women just don't realize that the diaphragm and the pelvic floor are a partnership and they work together. So when you're doing your pelvic floor exercises, you have to squeeze your pelvic floor as you breathe out. And then when you breathe in, you're going to relax it. So what I want you all to try and do right now, ladies, everyone watching it, pop your hands on the sides of your rib cage. Take a big deep breath in through your nose. Big deep breath. Now squeeze your pelvic floor, hold your pelvic floor, and exhale through your mouth. And keep squeezing your pelvic floor as you breathe out. And keep breathing out. Let your chest drop. Mary, let your chest drop. Let the diaphragm down. Now breathe in and relax. So imagine you're opening your back passage and you're letting all those pelvic floor muscles relax. And then last time, squeeze your pelvic floor and breathe out. And keep breathing out and hold that pelvic floor. And then relax. So this is how you do the exercises. We recommend that you do 10 slow squeezes like that, and then 10 fast ones at the end. And you're supposed to do them 3 times a day. But for a lot of women, I say at least aim to do them once a day for 5 minutes. And do them when you get into bed at night, so you can really feel what you're supposed to feel. You can really focus on the breath. There's lots of different positions you can do them in: lying down, sitting, standing, squatting, lunging. But it's learning how to do it properly first. And that's what I really help with in my clinic, because you cannot see your pelvic floor. You can see your elbow bend up and down, but you don't see your pelvic floor. So a lot of women are like, I don't know if I'm doing this properly. I don't know if I'm letting go. I don't know if I'm squeezing. I don't know if they're strong. I don't know if they're weak. So when they come in to see me, I examine their pelvic floor to really show them how to do the exercise properly. Because if you're doing it wrong, how are you going to make progress? And don't feel guilty for doing it wrong, because a lot of the time, again, it's like a feeling down there and we're just not maybe connected to that feeling. There are devices on the market, things that you can pop up into the vagina, use them on your app or on a smartphone to see if you're squeezing. But I always recommend going to a physio first, just learning the technique. You might not need any of those devices, but just to learn the technique. And then if you want to use a device, we can guide you a little bit more. So that's how you do your pelvic floor muscle exercises. And now we're going to talk about pregnancy. So firstly, in pregnancy, exercise is really important. In the first few weeks of pregnancy, you can feel exhausted, you can have nausea or vomiting, and you feel like you just don't have any energy to exercise, which is absolutely fine. But when your energy levels come back, you should be aiming to exercise. And the World Health Organization recommends 150 minutes per week, including 2 strength sessions. And your strength sessions could be weights, it could be yoga, Pilates, just making sure you're keeping your muscles strong. It's not just about going for walks every day. And of course, we want you to do your pelvic floor exercises because pregnancy is going to weaken them. Our main message with exercise is don't bump the bump. So if you're on a bike, we don't want you to fall off and fall onto the bump. We don't want you doing contact sports or football because we just are afraid you'll fall and bump your bump. But when it comes to things like even lifting weights or running, like you are allowed to do that as long as you have the energy levels for it, or as long as you don't feel like you're leaking or it's creating any pain in your body. So we are a lot more now like really supportive of exercise rather than telling pregnant women just to rest all the time. And pregnancy, like I say in the slide, really helps exercise with your blood pressure, diabetes, your overall heart health, helping you sleep at night in pregnancy, helping your mood. Exercise is so good for mood, and especially all those hormone fluctuations, and just also to keep on top of your weight a little bit as well. So huge benefits during pregnancy for exercising rather than just resting. However, pregnancy can bring symptoms with it. So I'm just going to stop that share again. So in terms of your pelvic floor, these lovely, nice muscles are up there supporting the pelvis. And then you're pregnant and you get this big bump and it shoves your diaphragm up and it shoves your pelvic floor down. So these lovely tight pelvic floor muscles tend to start to sag down a little bit with the weight of the bump and the swelling and the blood flow in your pelvis. So everything can become swollen, your vulva, everything. So your pelvic floor can often get quite weak in pregnancy. And this is when you'll start to hear about pelvic floor exercises. And a lot of women doing their yoga classes are like, oh gosh, I have to do my pelvic floor. But they might go, I don't know how to do my pelvic floor and I'm trying to squeeze and I don't know if anything's working. But this is why pregnancy really it all comes up, because it's when you start to have this weakness and when you might experience symptoms of leakage and prolapse for the first time in your life. I will get to that later and talk about that in a bit more detail. So the other things to look out for in pregnancy is pelvic girdle pain. What some women experience, and not all women, is a lot of pain around their pelvis, in their pubic bone, in the sides of their hips when they're sleeping at night, in their lower back, kind of below and to the side of their tailbone. And this is called pregnancy-related pelvic girdle pain. This is something physios can really help with. The main triggers will be things like walking and standing. So they'll really struggle to walk any distances. And as the pregnancy progresses, they really find it hard to even walk 50 or 100 meters. Some women have to go on crutches, unfortunately. But again, physio can really help this. What we would advise is that you keep exercising, but avoid long walks. So still go swimming, still try and do your pregnancy yoga and Pilates, but just to be avoiding a lot of walking and standing. The other things is sleeping. And when you're sleeping, you've got pain in the hips and it's really hard to turn in bed. So I have some great videos on my Instagram all about how to turn and how to sleep comfortably. But just to go into that now, for any of the pregnant ladies watching, like sleeping with 2 or 3 pillows between your knees. So those pregnancy pillows tend to be a bit small and soft. So extra pillows between your legs, like even 3 of them, going from your knee down to your ankle, can give great relief. And also my special little tip is a little towel, basically fold it up, just a little hand towel, and stick it under your rib cage or under the bump on the side you're lying on, and it really relieves the achiness you get in your hips, which can be really uncomfortable and make it hard to sleep. The other thing just here is preparing for labor is we really do in physio try and help women to prepare for vaginal deliveries to reduce the risk of injury, so reduce the risk of tearing. And our big focus with that is keeping active in labour, walking, squatting, sitting on a ball. You know, if you get an epidural very early, you tend to just be lying on your back flat in a bed, and that does not help the baby move down into your pelvis. So again, I'm just going to stop my screen share for a sec. With the pelvis, as the baby tries to make its way down, first it comes into the top of the pelvis and then it comes out the bottom of the pelvis. So if you're able to walk around a room and squat down low and sit on a ball and bounce on a ball, it really helps the baby get down into the pelvis. And as you're pushing the baby out, the worst position you can be in is flat on your back. We always say, like, try and do a poo lying flat on your back. It does not help anything to exit down. So lying on your side giving birth, going on all fours or up on your knees or even standing up, that way gravity really helps the baby come out. And if you can learn that in pregnancy, then we're not trying to fix you after you've had a baby and you now have injuries that we're trying to deal with. We're trying to prevent those injuries. So I'm someone who's never had an epidural. I've had 2 natural deliveries. I'm not saying it's not painful. It is 10 out of 10 pain on the visual analog score, but it's all about how a mum can deliver with reducing her risk of a bad tear or needing episiotomies or needing forceps delivery. And that is by the body being able to move into positions that help your baby to come out, reduce the length of your labor and reduce the length of the time that you're pushing that baby out, because you can move in a way that the baby feels like, oh, this is better, I can work my way down. So that's why we're real advocates for like non-medicated, non-instrumental deliveries, because we want the mum to come out as unscathed as she can, so that she's not struggling with symptoms, you know, for the rest of her life in some cases. But again, with Women's Health Physio, we do a little bit of prep work in our pregnancy appointments, and you will hear about this in pregnancy yoga and everything too, just all about, you know, trying to get a really effective birth going on. So next, so postpartum. So again, just episiotomies and tears. This can happen, you know, between your vagina and your back passage. There can be small tears or larger tears, or episiotomy is when they cut through it with a little scalpel just to make room for the baby. So again, with the type of delivery I was just talking about, we're trying to prevent those tears or reduce, or at least reduce the size of them. So make it a small tear instead of a large tear. And again, just with large tears, some women can experience a bit of fecal incontinence. So a little bit of poo gets out, or more leakage, or more pain afterwards when the scar tissue is healing, painful sex. And some women do need to go back in for little surgical procedures because their healing hasn't been great. So if we can have a better birth and we reduce the risk of that happening, then we don't have to deal with it after. That's, you know, prevention rather than cure. But again, if you've had an issue with your delivery, going to see a physio like me can really help you to recover, instead of just, I suppose, sitting at home and hoping and waiting that symptoms will improve in time. The other things that can happen after you've had your baby is leakage of urine, leakage of poo, urgency. So when you need to go to the toilet, you need to go now and you cannot wait. And that can be the same for bowel movements too. So whether it be I need a wee or I need a poo, once that feeling comes on, it's like you cannot wait. Frequency is another issue that you just feel like you need to wee all the time. For those mums who breastfeed, like low estrogen levels from breastfeeding quite mimic menopause symptoms. So some of these frequency and urgency will be due to your hormones and not just a weak pelvic floor. But again, it's something we do treat in my practice. Starting your pelvic floor exercise after you've had a baby is probably the most important thing. You will never look back in your life and regret doing your pelvic floor exercises. I have 70-odd-year-old women that come into me saying, I wish I'd have known this before. And other women telling me, I've done my pelvic floor ever since I had my first baby. So learning about pelvic floor in pregnancy is key, so that as soon as that baby's delivered or in the days after it, you're starting to strengthen these poor muscles that have been through a lot, through the delivery, through the pregnancy, pregnancy. Now your body's trying to heal and you're carrying a baby around, just like that lady in the picture. And it is not easy, because as a mum, you're trying to recover from a procedure and a pregnancy, and your body is deconditioned and it's hurting. But you have this little baby that is relying on you, and you've lack of sleep, and you're trying to eat properly. You don't even have time for a shower. And then we're saying, don't forget your pelvic floor exercises as well. But again, it's something you will look back on in your life, go, I'm so glad I just made time to look after my pelvic floor so that I'm not suffering with these issues that are impacting my quality of life as I get older. Returning to physical exercise is another thing we cover a lot. Like, some women are just so keen to get out running. The baby's out, 3 weeks later, they're back out trying to run again. This is too soon. The advice here is that you wait at least 12 weeks after you have your baby, that the impact on your pelvis from running is really not helpful, not good for leakage, not good for prolapse. It's just too much stress on the body. So waiting at least 12 weeks before you get out running or return to Gaelic football or any kind of high impact sport. But in the meantime, between 6 to 12 weeks, you could be working on your core. So strengthening your pelvic floor, strengthening your tummy, strengthening your glutes. So again, I always say to women, you've had a baby, your tummy was stretched out here. The baby comes out. It takes a few weeks for that tummy to start to flatten again. But in the meantime, your tummy muscles have completely weakened. They're really weak. Your glutes have completely switched off. Your back is in a big arch from pregnancy. So it's like you're trying to teach your body how to work again. So getting your core back to working, your hips back working, is really important before you start getting out there and running. And a lot of women who return to running too soon have real issues with incontinence, with leakage, with their pelvic floor, with prolapse. And they seem to say, nobody ever told me I shouldn't be back out there already. So I want you to hear that today and make sure that you don't rush back and start something like postnatal Pilates or postnatal exercise classes first, to just get your body back in a better baseline condition. When to seek medical attention. So, you have a 6-week check with your GP after you've had a baby. If you are experiencing pain where you had your tear or your scar from an episiotomy, you should really talk to your doctor, or a C-section. After 6 weeks, nearly all the pain should be gone. So if there is pain there, you really should bring that up to your GP or go back into the maternity hospital. You're under their care, under the public and private system, for 6 weeks after you've had your baby. So that's the time to get in there if you feel like things aren't healing properly. The Rotunda and Hollis Street have specialist perineal and postnatal clinics to help women who've had injuries during delivery. So you're better off to go in sooner rather than having to go on a waiting list in the following months. And don't be afraid to go and talk to your doctor if things don't feel right, or your public health nurse when she comes to visit. Also, if you have symptoms of prolapse, so if you feel a heavy, bulgy feeling in your pelvis, like something is hanging out or there's a tampon there, please go and see your GP and talk to them about that. Signs of infection too, that's a big one. So be it the C-section or the tear in the vagina, if you're feeling a lot of pain, if you're feeling temperature-like symptoms, like you have a bit of an infection, go and see your doctor, because it is common that infections happen. If there's an infection in the tear in your vagina, they do not resuture it. If the stitches have opened and there's an infection there, they do not stitch it back up. So I just want you to know that they just let it heal from the inside out, but you can go on antibiotics just to help with that infection. And the same with your C-section. If it's oozing a little bit, any pus coming out of it, or looks a bit angry, do go and see your GP and ask them to look at it for you. And like I've already mentioned, coming to see a women's health physio, I do a thing called a postnatal check. So anyone after 6 weeks, lots of women come to me, even if they don't have symptoms. I seem to be the only person that looks at their vagina, who looks at their C-section, who shows them how to do exercise to release it, to examine what changes have happened in their body during birth, to tell them what has happened, the changes that have happened, and how we're going to fix them, or what our plan is going forward. Because lots of women feel like after they've had a baby that they're just pretty much left, that they're really looked after during pregnancy, the baby's out, they've got one appointment with their GP at 6 weeks, and that's it. And lots of mums feel really quite abandoned and don't understand what symptoms they have or the change in their body and what's normal and what's not. And this is just what I'm telling you are the most common ones. There's lots of other things that happen, like losing your hair and regrowing hair, and the list is endless of postpartum symptoms, but these are the things that I really look at in my clinic. Different types of bladder problems we can have are a mix of urgency, which means, again, when you get the sensation to pee that you cannot hold on, like that you are rushing for the toilet. And that can be to do with like your nervous system, anxiety, hormones, pelvic floor not working the right way. So just to know there's different type of bladder problems. That might not mean leakage at all. Then you have frequency, which is going to the toilet too much. So on average, we should go every 2 to 3 hours. But sometimes, again, with pregnancy, postpartum, hormone changes, we're going a lot. And some women have really bad habits about going just in case. Every time they leave the house, every time they're about to go for a walk, they're peeing just to empty their bladder, and it gets their bladder in a bad habit. And the last one is leakage. And that is stress urinary incontinence when you cough, sneeze, jump, exercise. And that's usually to do with your pelvic floor muscles. So they're the 3 different types of bladder problem. And sometimes they can be mixed. You can get an urge, like a strong contraction, and then a bit of leakage with it. So just that you know what to look out for. And again, physio can really help with that. Prolapse, I'm going to go through really quickly. Just want to say with prolapse, you'll hear things like a bladder prolapse or a rectal prolapse, but actually it's the vaginal wall. So your vagina is like a tunnel of smooth muscle. It's not your pelvic floor. And sometimes little bits of the vaginal wall stretch a little bit. And when they stretch, they create like a little cul-de-sac. So as the bladder, which sits on top of the vagina, if you're getting a little bulge in the vagina, it's like the bladder can fall down into it a little bit. So you see from the pictures there with the bladder prolapse, it's like the bladder's falling in on top of the vagina. With the uterus prolapse, it's like the uterus is coming down a little bit towards the vaginal entrance. And then with the rectocele, it's like a little bit of the rectum is falling forward. So if someone is constipated and they're trying to push out a poo, that poo can get stuck in that little prolapse, and it's like they can't empty their bowel properly, and they stand up afterwards and feel like it's not fully empty. So again, prolapse is quite a common thing after pregnancy, and there can be just small prolapses or bigger prolapses, and they can rear their head again in the menopause and post-menopause age group, that they just become a little bit more symptomatic. So again, physio can help with that, and just so you're aware of what to look out for. And my last topic before Sarah takes over on menopause is painful sex. So this can be really common in younger women who haven't had babies, or women who've never had a vaginal delivery. Just to know that you can have a really tight pelvic floor, that you can have pain during sex in your 20s and 30s because your pelvic floor is kind of spasming. This can be called vaginismus or dyspareunia. It's really quite a common symptom. And if you experience painful sex, or after you've had a baby, that painful sex continues, you should reach out to a physio like me. Other things that can cause painful sex is low estrogen, again, after a baby, or menopause, because your vagina is a bit drier and the tissues are a bit thinner, and that can create a bit of pain during sex. Deeper pain can be things like endometriosis or issues at the cervix. Birth trauma can just create like psychological trauma to a woman that can create pain then during sex, and similarly with sexual assault. So women who've been through trauma that revolves around their pelvis and vagina, naturally their vagina can get quite tight and spasmy when they're trying to have penetrative sex because of their experiences. And again, just to highlight that these are things that women's health physios work with, because painful sex is really not talked about and women don't know where to go if they're experiencing it. So ladies, I'm going to hand you over to Sarah now, Dr. Sarah Callaghan. She is a specialist in menopause and perimenopause, and she's going to talk to you all about the symptoms to look out for. And I have her little symptom checker here.
Hi there. So Sarah Callaghan's my name. I'm a GP with a special interest in women's health.
Sarah.
Hi there, nice to see you. So yeah, one of my big focuses of interest is in hormone health in midlife. I deliberately kind of frame it that way because I think perimenopause and menopause are 2 words that have got that can be quite confusing and a little bit off-putting for women. So I just like to think of it as our hormones in midlife. And when I talk about midlife, I'm kind of talking anywhere from late 30s right through until, your late 50s. And basically it can be, your hormones can flare up at any time. So and they can cause a wide range of symptoms. Some of those symptoms are, the simplest way of putting it is if you don't feel like yourself, it may be due to your hormones. So there's lots of different reasons why, or lots of different symptoms that can occur. You see a whole bunch of them there on the symptom checker sheet, and that's actually only like the tip of the iceberg. And there's one particular one that isn't on that sheet that I think is so important to ask about: brain fog. So you feel muggy, you can't remember stuff, you lose your train of thought. You'll probably see me do it once or twice during this presentation. Then there's like other, there's so many. I was talking to a lady today who was getting recurrent mouth ulcers. There was a lady with burning feet, a lady with plantar fasciitis. None of those are on that list. So my worry about symptom checkers are that sometimes women are like nearly apologizing for not fitting into the checklist. So I say to them, look, if you don't feel like yourself, it's worth talking to a doctor who has an interest in women's health to have a hormone assessment. It may well turn out that there's nothing going on in terms of your hormones, but if there is, it's a possibility, and it's worth ruling it in or out. Just to kind of clarify this term perimenopause and menopause. So menopause is something we all kind of grew up knowing about. And I suppose I at least thought of it as like something people got in their mid-50s, their periods had stopped, and they were generally having sweats. But it doesn't always look like that. The word menopause actually means last period. And that happens when your ovaries aren't making enough estrogen to give you a menstrual cycle. But in the time coming up to that last period, that menopause, which actually comes from the Greek word, menos means period, and pauses means stop, so period stopping. So in the time coming up to that, you've got your perimenopause. And I think of it during that time like your ovaries are chugging. They're still producing estrogen, but the levels of estrogen are starting to fluctuate a little bit, and that can give rise to a whole pile of symptoms. Generally, there'll be some change in your period, but it may be very subtle. So a lot of women believe like, oh, I'm still having periods. It can't be my hormones. I can't be in perimenopause. The answer is yes, you can. So you may still have periods. They might be closer together, further apart. They might be heavier. So think of all the people you know who tell you that they're having heavy periods, or their PMS is worse. But they don't associate that with perimenopause or with the hormone issue. And to me, I'm straight away really interested in that, because I know that there's so much we can do to tackle that. And if you think about a woman who's been hit with, like I spoke to someone this morning who was having a week of horrible PMS, really irritable, tearful. And then she said, my period comes, her period's really heavy. And she's now losing another week, 10 days to really heavy periods. And that's like 2 weeks of her month gone every month. And she's only 41. So potentially her ovaries could chug along until she's 50, 52, 54, and she could lose a decade of her life with these horrible symptoms. So I'm pretty passionate about getting the word out to women, like there is so much we can do to stop this, to actually not just improve it, but to get rid of these symptoms. We can prevent heavy bleeding. We can treat, the PMS will resolve if we correct the hormone imbalance. And we can treat all the other symptoms, which she's probably beginning to get hints of, stuff like the headaches, the irritability, and this flushes is often a bit of a misnomer, sweats. What it actually means is a disorder of thermal regulation. So basically you're feeling hot when somebody else isn't feeling hot, or even you're feeling cold when someone else isn't feeling cold. So again, women are nearly apologizing because they're not waking up at night drenched in sweat. But yet when I ask them, do you feel hot when other people don't feel hot? They say yes. So that basically, that's my take on why hormone health is important. And then what do I do if I identify an issue? Well, I ask them, is it affecting your quality of life? And generally it's kind of obvious from the conversation, but some women have to kind of think about it. And some people say, not really. Like, I go for my runs and I eat well and I don't drink too much and I'm actually getting on okay. And I say, great, let's send you away. Keep working on your lifestyle and repeat your symptom checker in 3 months. And I just send them a photo, I send them away with a copy of it. And I say, just cover what you did today and keep an eye on it. And you might find that things stay nice and steady for you and that your healthy lifestyle allows you to manage it. And sometimes even with these chugging ovaries, they can actually kind of kick back in for a few months. So you have women who were worse when they were 41, then got a bit better for 6 months and then found, oh, it's come back again. So that's okay. We understand that. And we're watching kind of carefully, but not over urgently, to pick you up when you do possibly need additional support. And then if it's a case that the symptoms are affecting your quality of life, you've maxed out on your lifestyle changes, then we're talking about HRT. And that's hormone replacement. We're giving you back some estrogen to level out your, to steady out your levels and get rid of your symptoms. Not just improve, but get rid of, because if they're due to estrogen deficiency and we get your recipe of HRT right, they should go away. A lot of women I meet have settled for like a 50% improvement. That usually means the dose wasn't right, the medication, the type of product and delivery system wasn't right. Maybe they didn't absorb the gel or the patch properly and we should have tried something else. Or maybe there was a problem with the progesterone and they were getting a side effect, because I should say HRT has two components: the estrogen to fix your symptoms in a simple, by putting it very simplistically, and a progesterone if you have an intact womb. So if you still have your uterus, you haven't had a hysterectomy, you need progesterone to protect the lining of the womb from the estrogen, because estrogen on its own can cause thickening of the lining of the womb. So generally your HRT regime will include estrogen and progesterone. And then the really important thing to say to the person is, patience. This is not a simple thing like you take a box of HRT off a shelf. It's actually, there's several different products, there's different doses, there's different ways of using it. So we have to find the recipe that works for you. And it can take a little bit of time to do that, just as it takes time to find the right contraceptive pill for someone. But it's worth it, because you're looking at something that you might be using for quite an extended time, and that's really going to have a positive impact on your quality of life. And then the lifestyle part is obviously still going to be a really key part of the jigsaw of that woman's health. But okay, sometimes you need the hormones sorted in order to be able to engage with the lifestyle stuff. Like if you're feeling rotten, you're not sleeping, you're really anxious, you're aching all over, your joints are sore, then no matter what you do in terms of no matter how much you want to go for that exercise or eat healthily, if you're exhausted, it's really hard. So for some women, we just have to fix the hormones before we can get on with the lifestyle. So my job is kind of to figure out where the woman is at on the spectrum and then recommend the correct intervention. But certainly HRT is only one part of the jigsaw. The lifestyle is so important. And the lifestyle does cover a couple of things like exercise. We all have to be moving in some way. Ideally, some strength training, because we're all about maintaining our muscle mass and protecting our bones as we get into our 40s, because we're thinking about how our bones are going to be when we're 60 or 70 and how our muscle strength is going to be, and that whole use it or lose it thing. And then nutrition, we want a healthy diet, not too much processed food. We want not too much alcohol. Low risk limits are 11 units a week, a bottle and a half of wine. So it's really easy to hit that. So we've got to be, mindful of that, because excess alcohol use is particularly, well, obviously weight wise, it's not going to be good. Mood wise, it's not going to be good, but also breast cancer risk is significantly increased in people who drink alcohol above the low risk limits. So you've got your exercise, your nutrition, and then the self-care. And I'm really interested in this. In fact, I'm beginning to get more and more interested in it. And I'm going to clarify what I mean. I don't mean the exercise necessarily. I actually mean a separate thing. I mean, what piece of the week do we take, and what part of the day do we take to restore ourselves, like to actually renew ourselves? And I was just doing a talk with somebody earlier today who talked about the saucer and how you should be the cup and other people are the saucer. So basically we should fill ourselves, our cup, and then other people get the saucer. Whatever spills out of the cup goes onto the saucer. She explained it better, but anyway, you get what I mean. The idea is that we're renewing ourselves. So some quiet time in the day, and I know we don't have a lot of time, but could it be 10 minutes where you take 10 minutes out, to drink your coffee sitting in a sunny window, and to be aware that that's what you're doing, not to be scrolling on your phone, not to be trying to pay for the shopping or, order something or whatever. So just to take that time out to renew ourselves. And like if you're going out for your run and you've got your Fitbit on and you're counting calories, counting steps, and then you're rushing home and packing the dishwasher and putting the kids to bed, that's not actually renewal. That's exercise, which is different. Now, it may help you in certain ways, but it's actually not going to take the restorative renewal part. So our quiet time is actually really important, and I think it becomes more and more important in midlife. Hey Mary, as well, just if anyone wants to message me directly, because I know sometimes it can be hard to ask questions, or you mightn't think of them now, but I am on Instagram at Complete Women's Health, and you can always direct message me any question, and I do this question time on a Friday morning, or I can send you a quick reply. But I do think it's interesting there what you said about how you know, you're an individual, you know, each woman is an individual. And that's why I think we have to trust ourselves as women, like listen to your body and don't be afraid to take, you know, to believe, to sort of trust your own feelings. Like sometimes women talk about going to talk to somebody and being told, oh, you're anxious or you're depressed or you're this or you're that. But if you're not feeling right, you know, you have a right to get an answer. And sometimes you might have to try once or twice or three times to find that answer. But it's important to kind of trust yourself on it and keep going until you get to the bottom of it.
You're more than welcome to contact myself, Mary Heffernan, family health worker for the Finglas and Cabra Drugs and Alcohol Task Force, or Sarah Lenny, who is the health promotion worker for the Finglas and Cabra Local Drugs and Alcohol Task Force.